I'm Dr. David Bush. I'm a radiation oncologist at Loma Linda University Medical Center. And the publication we're going to be talking about is a randomized trial that we conducted here comparing proton beam to a procedure called TACE for patients with hepatocellular carcinoma. Back in the late 90s, when our proton therapy was operational and there was starting to be some data coming out from Japan showing good results using proton beam for hepatocellular carcinoma. And that caught the interest of myself and our hepatology group, and there was interest in initiating a trial investigating the treatment further. So we initiated a phase 2 trial. This was back in the late 1990s, and I think we treated 70, 80 patients or so on that trial and showed what were good results comparable to what had been seen in Japan. And after that was completed, kind of met with our hepatology colleagues to decide what the next step was. And we thought the best move was to try to do a comparative trial. And the comparative treatment that was chosen was TACE, because most of the patients treated on the phase 2 trial would have been treated with TACE had they not received proton beam. So we designed and opened the phase 3 randomized trial. So yeah, standard of care for hepatocellular carcinoma for patients with early stage disease limited to the liver. If they're non-cirrhotic, resection surgery would be the standard. That would probably be the minority of patients. Unfortunately, most patients also have underlying cirrhosis, which typically prevents surgery. So those would be patients who would be candidates for non-surgical treatment, of which there are several options. And none of these I don't think are necessarily standard, but the options would be radiofrequency ablation, TACE, Y90 or TARE, or external beam radiation such as proton beam. But each of these get applied to patients who meet the criteria for each of these individual treatments. And that's what patients usually get. TACE, right, so it's an acronym. It stands for transarterial chemoembolization. It's a procedure done by radiologists, interventional radiologists, where a catheter is inserted, threaded up into the liver, typically the portion of the liver where the tumor is, and then they inject a combination of both chemotherapy drugs and an embolic agent that then blocks the blood flow to that part of the liver. So the history of external beam radiation for hepatocellular carcinoma was actually very limited because standard X-ray therapies really couldn't deliver a high enough dose of radiation to the liver that would be effective for controlling the tumor without damaging the liver. So when proton beam came about, it was, applied early on for patients with liver tumors. It was first published in Japan. And the benefit is because of the physical properties of proton beam, where much higher doses could be safely delivered without damaging the rest of the liver and other nearby organs. It really allowed, for the first time, that a definitive dose of radiation could be delivered safely. That was first demonstrated in Japan, and then we kind of continued on with that. Right, so we designed our clinical trial, the randomized trial, started back in about 2018, and we were aiming to treat patients with newly diagnosed hepatocellular carcinoma, previously untreated. And we were limiting the population to kind of more the early stage type patients. These would be people who would be meeting the Milan or San Francisco transplant criteria. So these would be people generally with tumors about 5 centimeters or less, 3 and less in number, would be the population that would be included in the study. And then they were randomized to either TACE or to proton beam. So patients who were randomized to proton beam, the treatment they received dose-wise, they received 70.2 gray in 15 fractions over a 3-week course. And that was done also under an active breath hold to reduce the respiratory motion to, again, kind of cut down on the volume of that needed to be treated. And the TACE side, they received courses of TACE. They could receive multiple courses if needed. If there was only a partial response after the first procedure, that's a procedure that could be repeated if needed. And then after treatment, we track the results primarily using imaging, either CAT scan or MRI, to assess the results. So the results that we found when the data was analyzed was that the local control was significantly better with proton beam compared to TACE. By a pretty large margin, it was about a 5-fold improvement over the years of follow-up. And likewise, the progression-free survival was also statistically superior in the proton-treated patients. The overall survival looked to be about the same. That was our primary objective, was to detect a overall survival difference. Probably the main reason that we did not see that difference in our population was because the number of patients enrolled ended up being lower than what we had originally anticipated. Yeah, so part of our trial was to keep track of and compare the cost of each of these two treatments. So on the TACE side, because the treatment with TACE had to frequently be done in multiple sessions, that ended up being a more costly treatment to deliver than proton was, because of the frequency of repeat treatments that were needed. And then if we also add in patient care following the treatment, meaning patients who needed to be hospitalized for complications that were related to the treatment, if we factor that in, then we saw pretty substantial cost savings favoring proton beam, because of the kind of lesser need for hospitalization of patient within the 3-month window following the treatment. Yeah, so the main limitation to our trial would definitely be the relatively small number size of patients. Originally, we had intended to enroll over 200 patients. But for different reasons, the accrual was lower than expected. The main reasons for that would be that there were other competing treatments that kind of came online as the trial progressed. Probably number one on that list would be increased use of TARE or Y90 treatment, as well as more frequent use of ablation. So both of those treatment kind of increased their usage, which kind of cut into the number of patients that were available to enroll in our trial. And so at some point, it was just decided that we needed to kind of end the enrollment and analyze the results, which led to the publication that we have. So there are other ongoing trials investigating proton therapy for HCC. Probably the most notable would be a national trial in the US comparing proton beam to standard X-ray type treatment, usually delivered as SBRT. So it's a trial that's ongoing and haven't seen any results from that yet, but we'll certainly be interested in those results once they're made public. There are other trials going on in other countries and in the US. Most of these are, some are comparing proton beam to ablation. Some are combining proton thing with systemic agents. These are more phase 2 type of trials, but these are all the type of trials that are ongoing. So for patients who have unresectable hepatocellular carcinoma, there's multiple treatment options. I definitely think there's enough data to support the use of proton therapy as an option for patients. Kind of each of the available treatments has its own selection criteria, proton included, but it definitely has a place kind of in the choices of treatment and should be utilized that way.